In this section, I would talk about cardiopulmonary cerebral resuscitation with touching how do we approach an undifferentiated emergency patient. So let us assume you are in emergency and you just received a patient. So what should be your approach? Our approach should be on the initial impression which we get by seeing the patient. So when I see the patient, I get an impression, I have to make an impression whether the patient is conscious or unconscious. And my further approach would depend upon the initial impression which I am getting. So what is the approach of an emergency patient? The initial impression is what we have to see. So by initial impression, what we try to see? We try to see whether the patient is conscious or unconscious. Let us assume my patient is unconscious, okay? So when I think my patient is unconscious, when I find my patient is unconscious, in that case, we go for something called BLS approach, basic life support approach, basic life support approach. So we'll talk about basic life support approach, okay everyone? And if the impression of the patient, that patient seems conscious, patient is saying something, patient is in distress, respiratory distress, patient is pointing towards something, patient doesn't seem unconscious. So patient is conscious. In conscious patient, our approach, the first approach is primary approach. So I'll talk about what is primary approach, okay? So I'll talk about primary approach. Now, after primary approach, we go for secondary approach, secondary approach. Now we'll talk about secondary approach as well, okay? So let us first talk about how do we do the primary approach. After that, I will talk about BLS approach, okay? So let's talk about primary approach. So what is primary approach? Primary approach is also called ABCDE approach, ABCDE approach. So what is this A, B, C, D and E? Now A stands for airway. So when we approach the patient, when we see the patient, we need to see that any sign and symptoms indicating towards airway compromise. Because if patient's airway is compromised, it is obstructed, it is, let's say, unprotected, then there is a risk of the immediate death in the patient if we will not try to intervene, right? So we look for any airway compromise by seeing the patient's, any sound is coming from his airway, he is unable to maintain his airway, right? So we look for airway compromise, look for airway compromise, right? Sign and symptom of airway compromise. We have to focus on two things. We have to see the airway is patent or not, airway is protected or not. If anything is compromised, we intervene. Then B stands for breathing, right? We look for whether the patient has a regular breathing or not. If the patient has an unstable breathing pattern or use of accessory muscle, needs oxygen attachment, needs assistance in breathing, we will intervene. So we look for any compromise in breathing, any compromise in breathing. Here we can assess the patient by attaching some monitors also, like SpO2 probe, whether the patient is able to maintain the saturation or not, by seeing the chest movement of the patient, right? After securing the breathing of the patient, next thing which we need to see is circulation, whether the patient has adequate perfusion or not, his blood pressure is normal or not, he doesn't have a signs of shock, is not turning blue or cyanosed, patient is, let's say, his perfusion is being maintained. Then we measure his blood pressure, we see the ECG, any rhythm changes has happened which has brought the patient in current condition. So we assess the circulation by assessing the perfusion of the patient, by assessing the blood pressure of the patient, by seeing the ECG of the patient, and we intervene if immediate intervention is required. And then D stands for disability. Disability. So what disability we look for? Well, we look for neurological disability. We have to look for neurological disability. So how do we look for neurological disability in emergency? Well, we can go for GCS scoring, but more common and easy one is AVPU. AVPU. We see whether the patient is alert or not, whether the patient responds to the voice or not, right? Whether the patient is responding to pain or not, right? So we try to see, and whether the patient is unconscious, right? So if any time patient becomes unconscious, we go for BLS approach. E stands for exposure. E stands for exposure. So what we do, we expose the patient and try to find the cause why the patient has landed up in this situation. So once we are done with primary approach, ABCD approach. In ABCD approach, as I said, I approach all the ABCD, I assess them, then I intervene immediately, and then I reassess, and again required we intervene. So we have settled ABCDE, or we have assessed ABCD. Then I can go for the secondary approach, right? So what is the secondary approach, right? So let us talk about secondary approach. Now secondary approach is the cause finding approach. Now why the patient has landed up in this situation? We have to find it for a permanent solution of the current situation. So we take a quick history of the patient to find the cause, and quick history taken in emergency has a mnemonic to make us not forget anything important, is something called sample. So we take a sample history, we call it sample history. So what is the sample history? S stands for signs and symptom. Signs and symptom. So what is the current signs and symptoms of the patient pointing towards which system? Cardiovascular, respiratory, or any other system. Then we take the history of any allergy. We ask the immediate family member or the caregiver and maybe check the medical records of the patient and see whether the patient has any allergy or not. Then we take the medication history. Now patient may be on some medication, is overdosing of medication happened, or patient missed the medication, and that's why patient has landed up in this situation. So we take a medication history. Then we take a past relevant medical history. So past medical history. So patient was a patient of cardiac disease and now currently complaining of chest pain. There's a possibility that myocardial ischemia has been precipitated due to some reason. Patient on cardiac medication is having palpitation. So we need to know that what is the past medical history of the patient. And then L stands for last meal. Last meal. So number of times there is a risk of aspiration in the patient. Stroke patient has come to emergency. There is a risk of aspiration. We need to take the last when the patient has taken last meal, because if there is a risk of aspiration, we may intubate the patient. And E stands for events. So what are the scenario or the events which has landed up the patient in this situation? So this is secondary approach. So once in secondary approach, we take the history and we try to rule out all the causes which could have landed up the patient in this situation. And to remember the reversible causes is we need to remember 5 H's and 5 T's. So what is 5 H's and 5 T? We need to rule out hypoxia in the patient, whether the patient is hypoxic or not. We need to rule out hypothermia. Maybe the patient is hypothermic and that's why this situation. We need to rule out hyperkalemia, hyperkalemia, right? We need to rule out acidosis, that is H plus ion, right? Acidosis, and we need to rule out hypovolemia. So we need to rule out 5 H's, and also we need to rule out 5 T's. So what are 5 T's? First T is toxin. Patient has ingested some toxin. Maybe there is some antidote, we will use it. Then tension pneumothorax. Now patient is a trauma patient and chest injury. We will auscultate and we may find the cause why patient is in current situation. So tension pneumothorax. Then tamponade, cardiac tamponade. Well, I will auscultate and try to find, or maybe do a quick bedside ultrasound of the patient. Then thrombus. Thrombus, that is pulmonary thrombus, right? Or cardiac thrombus, right? So we will, or coronary thrombus, let's say pulmonary or coronary thrombus. So again, bedside ultrasound machine would very much help us in diagnosing these conditions. We'll try to rule out these reversible causes. Once we found a cause, we will treat the cause and the patient can become stabilized. So this is how we approach a patient who is conscious, right? Now, if the patient is unconscious, then we have to go for BLS approach. So what is the BLS approach is what we will discuss now, okay? And this is where our cardiopulmonary cerebral resuscitation discussion will start. So what is BLS approach? What is the BLS approach, right? What do I mean by BLS approach? So in BLS approach, if I get a patient in emergency and patient is unresponsive, seems unconscious, the first thing which we do is call for help. We call for help. But if I find a person out of hospital in unresponsive state, then before call for help, we have to do something called scene safety. So in BLS approach, any reason if the scene of the situation where the person is unresponsive seems unsafe, like there is in middle of the road, the patient is unresponsive, or in a house which has caught fire, patient is unresponsive, we cannot start assessing the patient there itself. The first thing we need to do is scene safety. After scene safety only, we will call for help. So I will call emergency and I will ask them to bring two things. One, I will ask them to bring bag valve mask, and also I will ask them to bring an automated external defibrillator, AED, automated external defibrillator. So I will ask them to bring these two things, okay? So once I have called emergency, then I will go back to the patient and I will assess two things of the patient. So my third thing will be, I would assess the patient's pulse and patient's breathing, right? Now, assessment of pulse will tell us about the cardiovascular status of the patient, and breathing would tell us about the respiratory status of the patient, right? So how would we assess the pulse and breathing of the patient, right? So we will assess the pulse and breathing in adult. We will assess the pulse and breathing in adult by palpating the carotid pulse. So in adult, we always palpate the carotid pulse, okay? So carotid pulse is the only pulse which is palpated in adult, okay? In pediatric, we can palpate what? We can palpate carotid or femoral, right? We palpate carotid or femoral. And in infant, always the brachial pulse. So we need to remember, for adult, it is nothing except carotid. In pediatric, carotid or femoral, and in infant, brachial pulse. Now remember that when you are assessing the pulse, simultaneously, when you are feeling for the pulse, your eyes should be on the chest of the patient. You have to see the chest movement for assessing the breathing. So breathing is assessed by seeing the movement of chest. So breathing is assessed in all, is assessed by movement of chest, right? Movement of chest. So question can be asked, a 7-year-old child, right? Which pulse you will assess for establishing cardiac arrest, right? So remember, you need to know the definition, the age definition of these three also. Infant means less than 1 year, less than 1 year, excluding newborn, So neonatal resuscitation is entirely different, excluding newborn, okay? Pediatric means 1 year to puberty. So when we are resuscitating a person, we see the signs of puberty, which is the axillary hair in case of boys and breast bud in the case of girls. And in adult, puberty onwards is adult. Okay, so this is how we see different pulse, assess the pulse and breathing of the patient. Now further movements depends upon presence or absence of these two, pulse and breathing. So we will assess pulse and breathing, and then the fourth thing would be the how we will approach the patient. Okay, so let's say patient can have three things: both pulse and breathing is present. Both pulse and breathing is present. If both are present, pulse and breathing is present, then patient is neither in cardiac arrest not in respiratory arrest. Patient is just unconscious. So whenever we get a person who seems unconscious but with pulse and breathing, in them we make the person in a recovery position, lateral position. This is a position which will prevent aspiration. So here, what is the intervention we do? We make the person in recovery position, that is lateral position, and wait for the ambulance to come if I am outside hospital, and in hospital I try to assess why the person has become unconscious by further evaluation. So we make the recovery position, that is lateral position, to prevent aspiration. Okay. Now the second thing which could be that pulse is present, okay, pulse is present but breathing absent, breathing is absent. Now this is something called respiratory arrest. This is respiratory arrest. So what we do in respiratory arrest, if someone has gone into respiratory arrest? In respiratory arrest, what we do is give rescue breath. So we give rescue breath. So what intervention? Rescue breath. So we need to know in adult what is the rate of rescue breath. It can be asked in exam. In pediatric, what is the pediatric and infant, what is the rate of rescue breath? So in adult, how many rescue breath we give? We give 10 breath in a minute, 1 breath every 6 seconds. So 10 breath per minute. And in child or infant, it is same. We give 20 to 30 breath per minute, 20 to 30 breath per minute. Okay. So this is rescue breath. So we give rescue breath, and every 2 minutes we again check for the pulse. No pulse, then the patient has gone into cardiac arrest. Pulse still present, patient is still in the respiratory arrest. So if patient is in respiratory arrest, we only give the rescue breath. Got it? Now the third scenario. So this was the first scenario when both is present. When the breathing is absent, pulse is present. This is the second scenario. The third scenario, both are absent. Both are absent. Then we will go for BLS support. The condition is cardiac arrest. So patient has gone into cardiac arrest. Got my point, everyone? So whenever we get a person in cardiac arrest, what do I mean by cardiac arrest? No pulse, no breathing. So when someone is in cardiac arrest, we go for high quality chest compression. We go for high quality chest compression. So what do I mean by high quality chest compression? Now high quality chest compression, right, has 5 parameters. What are the 5 parameters? Number 1, we start pushing hard, right? We start pushing hard. So push the chest hard, push hard. So how hard? In adult, it should be, the compression, chest compression should be at least 5 centimeter. Okay. In child, it should be about 5 centimeter, right? It should be about 5 centimeter. And in infant, it should be about 4 centimeter. So this is in centimeter. Arbitrarily we can remember that 1/3 of the anteroposterior diameter of the chest should be compressed. So 1/3 of the anteroposterior diameter should be compressed. So we have to push hard. The second thing is we need to push fast. So we need to push fast. How fast? The speed of chest compression should be 100 to 120 compression per minute. Now this is a universal compression rate. It would never change in any age group. Third is your allow complete recoil. So we have to allow complete recoil. Otherwise, what will happen? Chest, if you are not allowing the complete recoil of the heart will not get refilled. And when the next compression you will do, what will happen? It will be a useless, futile compression, which will not maintain any perfusion. Fourth would be minimum interruption in chest compression. Minimum interruption in chest compression. So minimum interruption in chest compression. Why we should have minimum interruption in chest compression? Because any interruption will make the cardiac output of the patient zero. So when you are interrupting, the perfusion is not being maintained. So whatever activity you are doing, you should have a minimum interruption in chest compression. And the last, just adequate ventilation. Just adequate ventilation. So what do I mean by just adequate ventilation? In case of adult, it is 10 breath per minute. In case of children, it is 20 to 30 breath per minute. Got it? So this is how we do the ventilation. So these are the points, the 5 important points for high quality chest compression. High quality chest compression. So we start with high quality chest compression, right? Now we do the high quality chest compression and ventilation, right, at a ratio of 30 compression to ventilation. So we do 5 cycle of compression and ventilation in a ratio of 30:2 in adult, always. We don't change the ratio at all. In pediatric and infant, right, it is 30:2 in case of single rescuer, and 15:2 in case of more than one rescuer. If more than one rescuer is there, we go for 15:2. Okay, so we do compression and ventilation in a ratio of 30:2 or 15:2 in infant and child if there is more than one rescuer for 5 cycle, which should take a minimum 2 minutes. Normally, when I am maintaining this high quality chest compression, it should take 2 minutes. After 2 minutes, again I will feel for the pulse. So after 2 minutes, that is after doing the 5 cycle, I will again feel for the pulse. Feel for pulse. Which pulse? I have already written. The pulse which we feel is carotid in adult, in pediatric carotid or femoral, and in infant the brachial. So we feel for the pulse. Still I couldn't feel the pulse. I would repeat the same thing. That is compression and ventilation. The high quality compression, ventilation, the high quality CPR. In the same ratio, everything same. For next 5 cycle, that will take 2 minutes. And again after 2 minutes, I will again feel for the pulse. So this would go on till a device arrives, till automated external defibrillator arrives. So what is this AED device? Automated external defibrillator. It's a small, compact, computerized device which has been designed and made thinking layperson in mind, right? You just have to open the device, and when you open the device starts giving the voice prompt. So when we open the device says that attach pads to the patient's bare chest. So AED, as soon as we get, we attach it. So first, let's say, order of AED is to attach the pads. There are pads available in AED, we have to attach the pads. Now position of the pads. Now, if this is the chest of the patient, there are 2 positions which can be used. This is the chest. So one is your anterolateral position. One pad is attached at just below the right clavicle. So this is the clavicle. So just below the right clavicle, and the other in left axilla, right? So this is anterolateral, and the other could be anteroposterior. Now on the pads, the image is given where you have to attach the pad. For anteroposterior, we attach it just left to the sternum and left to the vertebral column behind, right? So we attach the pads. After attaching the pad, the AED says, stop touching the patient, let me analyze the rhythm. So AED asks you to stop touching the patient. So at this point, we will leave the compression, right? So I stop touching the patient. When I stop touching the patient, AED takes 10 seconds to analyze the rhythm. So AED takes 10 to 12 seconds to analyze the rhythm. After analyzing the rhythm, the next thing which AED will say, the rhythm is whether the rhythm is shockable or the rhythm is non-shockable, right? If AED says shockable rhythm, we charge the AED. Now, we don't have to choose any voltage, anything. It is automated device. We charge and give shock as soon as possible. And then we resume compression ventilation. Resume compression and ventilation. If it is non-shockable, we just continue with compression ventilation. Continue compression and ventilation, right? So this is the how we approach. This is the BLS approach. So if I show you this flowchart, what all I have said, everything is written in this flowchart, and we will revise this flowchart. And few more things which I want to inform, I will inform for solving the questions. So what is the BLS approach? What is the BLS approach? The first thing is in BLS approach is something called scene safety. So we verify the scene safety, okay? After verifying the scene safety, next is we activate the emergency, shout for help, activate the emergency, ask them to bring automated external defibrillator. After calling for help, so this step is we call for help. So after calling for help, the next step is we look for pulse and breathing. We look for pulse and breathing. So we look for breathing and we will check the pulse. I told you three things can happen. The first is that normal breathing and pulse is present. In that case, we monitor the patient and make the patient in recovery position. Recovery position. Okay. So question was asked in exam. So when do you make recovery position during resuscitation? What are we doing? We are doing resuscitation. So this question was asked in exam. NEET. When do you make person in recovery position? Recovery position when during resuscitation. During resuscitation. So your answer has to be when normal breathing and pulse is present. Got my point? When normal breathing and pulse is present, then only we make the person in recovery position. Got my point? Okay. So next scenario is that no normal breathing but pulse is felt. So this is what I said is respiratory arrest. Respiratory arrest. So when someone is in respiratory arrest, we provide with rescue breathing. 1 breath every 6 seconds or 10 breath in a minute. And we check for the pulse every 2 minutes, right? If there is no pulse, we start the CPR, okay? So this is how we manage in respiratory arrest, okay? If I found out that patient who has gone into respiratory arrest has taken opioid or let's say drug overdose or something, if we have antidote like naloxone available, we would immediately give to the patient. It would call an immediate reversal. Now, third scenario is no breathing, no pulse. Now, gasping, remember, like this. This is gasping, and gasping is never breathing. If someone is doing like this is gas, we consider it as no breathing. So, if there is no breathing, no pulse, we start chest compression, high quality CPR. I told you the 5 points of high quality CPR. We performs the cycle of 30 compression to ventilation. When it is 15-2, we have already discussed. And we use AED as soon as it is available. So this is again asked in question, as soon as available. So it has to be used as soon as available, right? Once the AED arrives, immediately we attach it to patient bare chest. The AED checks the rhythm. If the rhythm is shockable, we give a shock and resume compression ventilation. Non-shockable, we resume compression ventilation immediately. We go on doing this till the patient starts moving, the resuscitation is successful, or the advanced life support team has taken over. So we continue until the advanced life support team takes over or the patient victim starts to move. So this is BLS. So many questions every year is asked on BLS. What are the questions asked on BLS? Well, number one, they ask, what are the points for high quality CPR? Number two, they ask that what are, let's say, in different scenario, what will be our approach? Number three, they ask, what is the sequence of BLS? That is scene safety, call for help, assess pulse and breathing, then start high quality chest compression, right? So we need to know the sequence. So sequence has to be followed. So all these questions are asked on basic life support. And of course, it has also been asked, when is AED attached? As soon as possible, right? And AED can be attached when you are doing the chest compression. So one more thing I want to tell you, can be asked in exam. How do you do the chest compression? Now, for chest compression, we are at the side of the victim and our one hand is placed on lower 1/3 of the sternum. So lower 1/3 of the sternum, right? Lower 1/3 of sternum, right? This is the site for putting the hand, lower 1/3 of sternum. And with our other hand, we cup the lowering hand and with keeping our elbow straight, we start doing chest compression. So lower 1/3 of sternum, we put the palm and we start high quality chest compression, right? Okay, so we do the compression and we allow the complete recoil. So why do we allow complete recoil? Because during your recoil, the heart gets refilled, right? And refilling of the heart is very much important. So this is our basic life support, okay? Now, till what time we go on doing? Till the advanced life support team takes over. So when the advanced life support teams takes over, the first thing they do, they attach ECG, because now the management will be done according to the rhythm. In BLS, we are not seeing the rhythm. AED is analyzing the rhythm, right? I told you the AED has been designed keeping in the mind layperson. BLS has been designed keeping in the mind layperson. It is given by doctors, it is given by layperson. ACLS is designed for doctors. So now everything we would do here would need the medical knowledge. So first thing what we will do, we will attach ECG and we will try to recognize the rhythm. Now, cardiac arrest rhythm is of two types. So rhythm of cardiac arrest is of two types, divided into shockable, non-shockable. So what is the shockable rhythm? The shockable rhythms are ventricular fibrillation, right? This is the shockable rhythm. And your pulseless ventricular tachycardia, pulseless ventricular tachycardia, right? So VF and we call it VT, okay? These are shockable rhythm. Now, why are these shockable rhythm? Because in VF, ventricular fibrillation, the heart is fibrillating like pop, 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 pop. And this is not a electrical activity which will get converted into perfusing rhythm. So this pop, pop, pop is not getting converted into cardiac output. So what we do, we give shock and heart stops. And then the heart will resume its rhythm. It would be sinus, possibility of sinus rhythm, right? Natural rhythm of heart is sinus rhythm, right? So we stop the heart and pray that heart resume its normal rhythm, right? And in pulseless VT, heart is beating at a very high rate. That high rate, that the filling of the heart is not possible. So there is no cardiac output. So again, we do the same thing. We stop the heart, What happens? The heart resumes its rhythm. There's a possibility it would be sinus rhythm. So that's why these are shockable rhythm. Non-shockable is asystole. Asystole, there is no rhythm, straight line of the heart. So no use of giving shock. And fourth is pulseless electrical activity, or popularly called PEA, pulseless electrical activity, or popularly called PEA. This is possibility that there is no pulse. How we define it? There is no pulse, but there is an electrical activity, and that electrical activity maybe a normal electrical activity of the heart, right? So we need not give shock to stop the heart, because heart has a normal electrical activity. Due to some reason, the cardiac output is not getting maintained. That is pulseless electrical activity. Okay, so now we will manage the cardiac arrest according to rhythm. So management of ventricular fibrillation and pulseless ventricular tachycardia is similar, and management of asystole and pulseless electrical activity is similar. So first I will discuss the management of shockable rhythm, and then I will discuss management of non-shockable rhythm. But one thing you should be crystal clear, that if the rhythm is shockable, we need to give shock as soon as possible. That is the prerequisite. Okay. Non-shockable rhythm, we just do CPR and give emergency drugs. But in shockable rhythm, give shock as soon as possible along with CPR. So we will discuss this in detail. Okay. So first let us see that what rhythms is VF or VT, what kind of rhythm we will see in the monitor. So this, as you can see on the screen, this is ventricular fibrillation. This is ventricular fibrillation. Okay, ventricular fibrillation. Now, what do I mean by ventricular fibrillation? Well, if you give a pen to a 1-year-old child who doesn't know how to write or do anything on the pen and paper, whatever lines he draws on the paper with the pen which you have given him, that lines is ventricular fibrillation. What do I mean? This has no morphology, just some line around the baseline. No morphology, some line around the baseline. So even if I am drawing it unconsciously, I'm kind of making constant kind of lines on the ECG strip. But it is something like this. No morphology, nothing, right? So this is ventricular fibrillation. Ventricular fibrillation. The ventricle is fibrillating. Now, what is pulseless ventricular tachycardia? Now, this has a uniform waveform. It has a uniform waveform, right? And this rate is very high, but the waveform is uniform. This is pulseless ventricular tachycardia. So the tachycardia is from tachyarrhythmia or tachycardia, whatever you say, is because of the origin of impulse, chaotic impulse from ventricle. So this is pulseless ventricular tachycardia. This could be of same morphology, and sometimes it could be of a few different morphology. We call it polymorphic or monomorphic ventricular tachycardia. But any ventricular tachycardia without pulse comes under cardiac arrest. So these two rhythm, VF and VT, they are shockable rhythm, and we'll discuss their management. Now, straight line on the screen, no, nothing, just a straight line on the screen. This is asystole. This is asystole. And whenever we get a straight line, what we do, we try to increase the gain, right? We check the ECG leads whether it is properly attached or not, try to check, increase the gain and see that it is really straight line or maybe some fine ventricular fibrillation. Why do we need to differentiate between VF and asystole? Because VF has a definitive management, that is shock. Asystole, we don't have to give shock, we just have to do CPR. It doesn't have a definitive management. So that's why if we discover it's VF, then we are at a better place. Okay, but asystole is just a straight line. Okay, now pulseless ventricular tachycardia, I already told you, pulseless electrical activity. Pulseless electrical activity, I already told you, PEA. This means no pulse and any electrical activity which is not VF, which we discussed, which is not this VF, which is not VT, and which is not straight line. So not VF, not VT, any other electrical activity. Asystole, there is no electrical activity. Any other electrical activity, it could be sinus rhythm as well, is pulseless electrical activity. Okay. Now, management of shockable rhythm. So these two are shockable rhythm. How do we manage these two rhythm of cardiac arrest? So if you see this flow chart, I'll show you the flow chart. Now, this is the adult ACLS flow chart, Advanced Cardiac Life Support Management flow chart. So we have started the CPR of the patient, the BLS has been started. We attach the monitor to the patient, that is the ECG electrode is attached, and we see the rhythm. if the rhythm is shockable or not. So rhythm is shockable. What would be the rhythm? It could be either VF or pulseless ventricular tachycardia. So what we do, we give shock as soon as possible. We try to charge the defibrillator and give shock as soon as possible. Okay, we give the shock and then continue CPR for 2 minutes. Try to secure the IV line. If we don't get the IV line, we go for interosseous line. Now, we do CPR for 2 minutes. Again, we check the rhythm. If the rhythm is still shockable, we give the shock again. And we again resume CPR for next 2 minutes. Then after, let's second shock, we start during CPR, we start giving the patient the emergency drug like epinephrine every 3 to 5 minutes. And we try to intubate the patient if we can intubate in between the CPR as soon as possible. Now, after 2 minutes of CPR, again we check the rhythm. Rhythm is still shockable, again we give the shock. We continue with CPR. And now after epinephrine, another drug which can be given to the patient is amiodarone or lidocaine, right? Amiodarone or lidocaine, I'll talk about them. And we try to find the cause and treat the treatable cause. If the shock is not reversing, if the cardiac arrest rhythm is not reversing even after multiple shocks, right? So we try to find the cause. If we'll treat the cause, the chances of reversal from cardiac arrest would be better. Okay, so now let's say what I discussed just now, I will just repeat. So ventricular fibrillation and pulseless ventricular tachycardia is the rhythm we got in ECG when I attached monitors to the patient. So what I do in VF and pulseless ventricular tachycardia, I give shock as soon as possible. So what about how much should be the energy of shock? What we give, I will just discuss in a moment. So I give shock and start CPR for next 2 minutes, right? And again after 2 minutes, we check for the rhythm. Still it is VF and pulseless ventricular tachycardia after 2 minutes. We again give shock as soon as possible, right? We charge and give the shock and again do CPR for 2 minutes. Now during CPR, right, what we start doing, we start giving the emergency drug because already in between some time I have secured the IV line. So I give the emergency drug. Now what are the emergency drug which we have to give in shockable rhythm? 2 emergency drugs which we can give. We start with adrenaline. So adrenaline is the first emergency drug. So what is the dose of adrenaline? Very commonly asked in exam. We give 1 milligram, 1 in 10,000, right? Adrenaline, 1 milligram, 1 in 10,000. And we repeat every 3 to 5 minutes. We repeat every 3 to 5 minutes, okay? So we give adrenaline 1 in 10,000 and we repeat every 3 to 5 minutes adrenaline, okay? So I give emergency drug, I start with adrenaline, okay? After 2 minutes, again I check for the rhythm and rhythm is still VF and VT, still VF and VT. So again I will give shock. Every 2 minutes, if the rhythm is shockable rhythm, we will give the shock. After giving the shock, again I will continue with CPR for next 2 minutes and I may give the another emergency drug, that is amiodarone. We can give amiodarone. Or if amiodarone is not available, I can give lidocaine. So what is the dose of amiodarone? What is the dose of amiodarone? Now amiodarone is an antiarrhythmic agent and it increases the sensitivity of heart to the shock. So that's why if the previous shocks are not able to convert the rhythm into sinus rhythm, there's a possibility that after giving amiodarone, the rhythm will get converted into sinus rhythm. So amiodarone, what is the dose? We give 300 milligram of amiodarone, right? First dose. The antiarrhythmic dose of amiodarone is 150 milligram, but cardiac arrest dose is 300 milligram. And we can repeat it by 150 milligram as the second dose. So this is the first, this is the second dose. If amiodarone is not available, then I can use lidocaine. Lidocaine. Now lidocaine, what is the dose? 1.5. Lidocaine, the dose is 1.5 milligram per kg body weight. This is the dose of lidocaine, first dose. And if this is not, we want to repeat the dose, I will repeat 0.5 milligram per kg body weight. So these are the emergency drug which I am giving in shockable rhythm. So what are the interventions which we are doing in the shockable rhythm? We are doing apart from CPR. So CPR, so we are continuing. Any cardiac arrest, we have to do CPR. We are giving shock as soon as possible, and we are giving emergency drug. There are two emergency drugs, adrenaline and amiodarone. Right, everyone? If amiodarone is not available, then I give lidocaine. Right? And we try to find the reversible cause. We try to find reversible cause. Right? We try to check for the 5 H's and 5 T's and try to reverse them, and then the possibility of conversion of cardiac arrest into sinus rhythm would become better. So this is how we manage VF and PVT. So any question? They say patient is unconscious, CPR is undergoing, and when ECG was attached, this was the rhythm. That's VT. Or this was the rhythm. That's VF. What would be immediately management done by you? CPR is continuing. What immediately we will do? We will give shock. Immediately we will defibrillate. Defibrillation would be done. Okay. So they can ask you, what is the emergency drug given in shockable rhythm? So 3 drugs, that is adrenaline, amiodarone, or lidocaine. No atropine, no soda bicarb, nothing else. Have I mentioned it? No. So what drug I have mentioned? I have mentioned ADR, amiodarone, lidocaine. Nothing else, guys. So what is being told, that you have to remember. You don't have to think about a drug from your end, because that's what students do. They think atropine can be given. No, guys. Atropine is not given in cardiac arrest. Got it? It is only given in symptomatic bradycardia. Okay. Then how do we manage asystole and pulseless electrical activity, which are the non-shockable rhythm? Non-shockable rhythm. So how do we manage the asystole and pulseless electrical activity? So other part of the ACLS algorithm. If it is asystole or pulseless electrical activity, we do CPR and give adrenaline as soon as possible. We take a IV IOXs, we give adrenaline every 3 to 5 minutes, we intubate the patient. We again check for the rhythm. The rhythm is still non-shockable. Then we again do CPR, try to treat the reversible cause, and again check for the rhythm after 2 minutes. Still it is non-shockable. We continue with the CPR and adrenaline and nothing else, and try to treat the reversible causes. So management of non-shockable rhythm. We need to do CPR, as we have discussed CPR. We need to do CPR. We need to give adrenaline. Adrenaline 1 milligram, 1 in 10,000, right? As soon as possible. Repeat every 3 to 5 minutes. We repeat every 3 to 5 minutes, the adrenaline. Again, we do CPR. We continue with CPR, like every 2 minutes, we do CPR for 2 minutes. We look for the rhythm. Rhythm is still the asystole or pulseless electrical activity. We continue with CPR. We don't give shock, and we continue with adrenaline every 3 to 5 minutes. Nothing else. No amiodarone, no shock. So I'm writing it in big. No shock in non-shockable rhythm, and no amiodarone. No amiodarone, that means no lidocaine also. Lidocaine is used as an alternative to amiodarone. So only and only adrenaline and CPR is the management of non-shockable rhythm. Got it? So this is how we manage the non-shockable rhythm. If they say a patient was in cardiac arrest, CPR was undergoing, on the ECG straight line was being seen, and adrenaline 2 dose was given. What is the other drug you give? So people tends to think, what is the other drug? So I have to say some other drug. Guys, no. In non-shockable rhythm, adrenaline, 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 and adrenaline. Second dose drug, third dose of adrenaline, then fourth dose of adrenaline, then fifth dose of adrenaline, every 3 to 5 minutes. That's no other drug. This is the drug that we go on repeating, There is no upper limit of giving adrenaline. There is no upper limit that we have given 10 doses of adrenaline, now I can't give. Till a patient is in cardiac arrest, and till, let's say, we are doing the resuscitation, we need to repeat ADR every 3 to 5 minutes. Okay? And in shockable rhythm, every 2 minutes, we need to give shock till the rhythm is shockable rhythm. I have given 10 shocks. No, I will not give shocks. Lot of shocks I have given. No, guys. We start giving shock every 2 minutes. We repeat if the rhythm is shockable rhythm. Yes, there is less chance that shock will convert it into sinus rhythm. If it is not converting, then we try to just increase the energy of shock, the subsequent shocks. But we can give shock as many times as possible till we are doing the resuscitation. There is no upper limit. Okay, so keep it in mind. So this is how we manage the adult cardiac arrest. So now let us just repeat what few things that I have already discussed. So CPR quality, so high quality CPR, how it is decided? We push hard, that is at least 5 centimeter. We push fast, that is 100 to 120 compression per minute. Minimize the interruption of compression, right? Minimize the interruption of compression. Avoid excessive ventilation. We change the compressor every 2 minutes or sooner if fatigue. No advanced airway. We go for 30 compression to ventilation ratio in adult always. In pediatric, 30 compression to ventilation if one rescuer is there and more than one rescuer, 15:2. Then we can use capnography. We have discussed in monitoring that we can attach capno to the advanced airway when we are doing the resuscitation, and the quality of compression can be assessed. We need to keep the EtCO2 value above 20 mm of Hg. This tells us the compression is good. If it is below 10, that means ineffective compression. Okay. Now, what is the shock for defibrillation? Most of the defibrillator that we have nowadays, it's a biphasic one, right? You will seldom get a monophasic nowadays. So let us first tell you about biphasic. Biphasic, what do I mean by biphasic? That when I have attached the defibrillator pads, right, the current goes from one pad to other and then travel back to the first pad. So there is a complete loop. So this current, the heart is in between, it is passing, this current is passing twice through the heart. So a very small energy can be used to convert the heart from a chaotic rhythm to sinus rhythm. A very small energy can stop the heart, okay? But when we are using monophasic, then in monophasic, only once the current is passing. So we need a high energy current, high energy for making the heart stop, right? So if you use high energy, it has its own repercussion. And there's a possibility that even if you resuscitate the patient, there are some other complications which can happen, right? But of course, when we are doing resuscitation, we don't care about other complications, okay? So if it's biphasic, every defibrillator, the manufacturer who has made it, they recommend a certain energy for defibrillation. We should always choose that as our first energy, right? So if it's, let's say, 120 joules is recommended, I start with 120 joules and I give an increment of 20 on every subsequent shock, let's say to 200 joules. If there is more, and let's say energy can be given by that defibrillator, I can use that also, right? So biphasic, we start with 120. Okay. Now, if we don't know what is the manufacturer recommendation, I'll go for the highest energy which can be delivered by that device. Okay. Second and subsequent doses should be equivalent and higher dose may be considered, right? We should consider higher dose when first dose of shock is not converting the heart into sinus rhythm. And for monophasic, we start with 360 joules. Monophasic, we start with 360 joules. Biphasic, we start with 120 joules. We can go on increasing, right? We can go on increasing it, let's say, to 200 joules. And if I don't know what is the manufacturer recommendation, I would go for the highest possible energy which is delivered by that defibrillator. So this is about the shock for defibrillation. Got it? So this is how we do CPR. 5H, 5Ts I have already discussed with you. Now I would I will discuss about drugs again which we use in resuscitation. Questions are asked, what are the drugs used in resuscitation? So we have epinephrine, the dose 1 milligram every 3 to 5 minutes, and the dilution should be 1 in 10,000. And how can we give it? Intravenous or intraosseous. These are the only two recommended way of giving the drug, IV or interosseous, right? We should not give it by any other routes. If we are able to secure the IV line, good enough. If not, it is easy to secure an interosseous line with the help of interosseous cannula. Okay, the second drug is amiodarone, IV or interosseous. The dose is 300 milligram bolus, the first dose, and the second dose is 150 milligram is the second dose. So only 2 doses are given. ADR, there is no upper limit, every 3 to 5 minutes we repeat. And if we don't have amiodarone, we use lidocaine, IV or intravenous, and the dose is 1 to 1.5 milligram per kg, the first dose, and second 0.5 milligram per kg body weight. So if I divide, right, if I divide that for shockable and non-shockable, what we are using, so drugs, shockable rhythm, for shockable rhythm, we are using ADR, right, amiodarone and lidocaine, amiodarone or lidocaine. But for non-shockable rhythm, for non-shockable, it is only adrenaline, nothing else, right? So keep it in mind. And there is no other drug which is used in resuscitation. No atropine, no soda bicarb, no other drug. These are the only drug which we use during resuscitation. Plus, we can use any other drug if we know the specific cause and the drug is antidote. Like if it is opioid overdose, we can in between give naloxone to the patient, right, by IV or intravenous line, right. This is the etiology specific. If it is the local anesthetic systemic toxicity last, then we can start 20% intralipid emulsion, okay. So the etiology specific treatment we only do if we know the reason, exact reason why the patient has gone into cardiac arrest. So this is about the drug. Now let us talk about the advanced airway. As I said, in between the management of resuscitation, that any time in between, if we can secure the airway, advanced airway, without disturbing the chest compression, we should secure the airway. And we should try to go for any device, endotracheal tube or supraglottic airway device, whichever we are more comfortable in the particular scenario. What is recommended, once you have put the advanced airway, that is ETT or supraglottic airway device, always confirm it with a capnography. So always confirm with a waveform capnography. And once you have secured the you have attached the capno, do not remove it, because capno will give you a lot of information. It will tell you about the quality of CPR. So quality of CPR would be analyzed by the capno. We have already discussed that if the EtCO2 value is more than 20, then we are doing a good resuscitation. If it is less than 20, less than 10, then our compression is not adequate. Then once we have secured an ETT or a supraglottic airway device, right, we should give 1 breath every 6 seconds. That is 10 breaths in a minute for an adult. Now, once the advanced airway is there, the 30:2 ventilation and compression and ventilation ratio is need not to be required, because when you are giving 2 ventilation, you have to stop the compression at that point of time. Now both can be done independent of one another. Compression at the rate of 100 to 120 per minute, ventilation at the rate of 10 breath per minute. So we don't need to stop compression anytime. So that's why the benefit is that we should secure advanced airway if we are comfortable that we can secure the advanced airway without disturbing the compression. Compression is the most important thing during resuscitation. Okay, the next important thing for us is how would we get an idea that spontaneous circulation has returned? We can feel for the pulse of the patient if there is any change in the rhythm. So on monitor, if any change in rhythm is seen, right, from the previous rhythm, any change in the rhythm is seen, right, we always feel for the pulse of the patient. In between, otherwise we don't feel for the pulse, right? And if EtCO2, that is from, let's say, small 20, 25, it has suddenly shown a big increase, let's say has become more than 40. This means return of spontaneous circulation, a very early indicator of return of spontaneous circulation, right? And already I have discussed with you the 5H and 5Ts. 5Hs and 5Ts, which are the reversible cause of cardiac arrest. Reversible cause, and we need to identify them and treat them. So in between your resuscitation, if you have sent a sample and you receive the report, you can manage if you can see any of these reversible cause is leading to cardiac arrest, right? So if you are resuscitating and you are not getting the result, always send the investigation and look for a reversible cause. Got it? Okay, now next thing which I want to discuss with you, difference between adult, pediatric and infant resuscitation, right? So just in the end, I would summarize that how adults resuscitation, how a pediatric resuscitation, how a infant resuscitation is different. Okay, adult means above puberty, already I have told you, right? Pediatric means from more than 1 year to puberty. So 1 year to puberty. And infant less than 1 year, excluding newborn. So excluding newborn. Newborn resuscitation is different. So what is the first difference? First difference is the which pulse you assess to establish the cardiac arrest. In adult, always carotid. No other pulse is used. It is the pulse which we can have a feel if there is any cardiac output of the heart. Pediatric, we go for carotid or we go for femoral. And in infant, we go for brachial, always brachial. Okay. So this is for the pulse. Next, the compression and ventilation ratio. Compression ventilation ratio during BLS. For compression ventilation ratio in adult, always 30:2. So I am writing here always. I mean there is no difference, always. And for pediatric and infant, we go for 30:2 when there are only one person, and 15:2 when there is more than one person doing the resuscitation. Got it? The next is, which we need to know, how do we do the compression, chest compression? So what is the depth and what is the way of doing chest compression? So little difference in chest compression. Now depth of chest compression in adult should be at least minimum 5 centimeter. In pediatric, it should be about 5 centimeter, and in infant, it should be about 4 centimeter. Okay. The way of chest compression in adult, we go for two-hand technique always for two-hand technique. And in pediatric, depending upon the build of child, a small build child, we go for one-hand technique, and a larger build child, we go like adult, two-hand. Okay. And in infant, we go for either one finger compression or thumb encircling technique. So what is thumb encircling technique? In which we encircle the body of the patient, and with both our thumb at lower 1/3 of the sternum, we are giving us TB compression. This is a very good mode of chest compression. But this mode of chest compression, we practice in infant only when we have more than one person for resuscitation. Why? Because we are doing the thumb encircling technique from the rear end. So when I will have to give the breath, I will again have to travel to the head end of the patient. That will waste my time. So if I have more than one person, I can remain at my side. So we go for thumb encircling technique. Definitely it's a better technique, but we do it when we have more than one rescuer. So this is the way of chest compression. Now the speed of chest compression, that is rate, that is 100 to 120, is same in everyone. So rate is same in everyone. We don't change the rate. So always remember, the rate of chest compression for all, it is 100 to 120 compression per minute. Got it? So this is for the rate. Now what is other thing which is changed? Let's talk about the energy of defibrillation. So defibrillation energy. For adult, we always give, we start from 120 to 200 joules. And for child and infant, we start with 2 joules per kg body weight. We can increase to 4 joules per kg body weight. We can increase to 8 joules per kg body weight. Okay. So this is the difference in the choice of defibrillation energy. Apart from this, The drugs which we are giving, same, right? The airway placement and way of identifying whether the compression is good or not, everything is same. There is no difference. The only difference is what I just now told you. Otherwise, everything is same, right? The rate is same, 100 to 120 compression. The drug used during resuscitation is same, right? Looking for the cause is same. Everything rest is same in adult, child and infant. So this is the way of resuscitation that we practice in adult patient, child and infant. So we have discussed it in detail, and a lot of questions are asked about this topic in exam. Each and every point that I have told you is an exam question. So keep it in mind.